Good afternoon, John Snyder here, back for Lunch and Learn on a beautiful Thursday afternoon. We're happy to have Dr. Jay Simon back in the hot seat today, talking to us about what a pain in the leg. Next slide, Jason. Just want to tease upcoming Lunch and Learns. We want to remind folks that next week's a holiday, a hospital holiday, so we won't be here. Feel free to take that 30 minutes. How's it going, Jason? Take those 30 minutes. There we go. Take those 30 minutes and go use one of our archives. Talks that they're always up on YouTube, Newton-Wellesley Medical Group Lunch and Learn, also on our intranet, and the web link is right there for our talks. On the following week, we're going to have Dr. David Ramsden talking about an anterior total hip arthroplasty. So a couple of orthopedic talks back and back. And then the following week, I'm excited. The following week is Thanksgiving. So again, we won't be here. But then after that, we will have a great talk about the pancreatic cyst conference and the cyst clinic, which I don't think a lot of our PCPs know about. So I wanted to get Dr. Kadana in front of everybody to tell them about this great service that's available to you and your patients with all those IPMNs you're trying to manage. Next slide, please. And then I'm going to say only 2 seconds about the orthopedic walk-in, because I'm sure Dr. Simon's going to talk about it, but it's open Monday to Friday, 8 to 8. And Saturday and Sunday, 8 to 1. Thank you. There it is. Full-on X-ray, casting, bracing, all there. Staffed by orthopedic physician assistants and board-certified orthopedic surgeons from Newton-Wellesley Medical Group and Mass General Brigham Sports Medicine. All yours, Jason. Thank you. Thanks for coming. Thanks for doing it. And you're on. There you go. Thank you.
Thanks, John. I apologize for this. There's a little bit of a lag, so if there's any hiccup, by all means, let me know. Because it doesn't look like the slides are advancing very quickly. John, do you have a copy of this as well?
Can you see mine now?
I can. I don't know why things aren't moving. All right, well, I will start talking in the meantime. I'm going to try to screen share again and see if it works.
Hang on a second. So you have something in here that it's not liking.
All right, bear with me. So I will start talking about lovely things without showing you what is going on, and then we will catch up. So,
Jason, can you see my screen at all or no?
I can.
Yes?
Yep.
Okay, go ahead.
All right, so today's topic is what a pain in the leg, which is well, we're going through all the slides now. I can't talk that quickly.
Go ahead, sorry about that.
So we're going to go through a quick little overview of 5 common leg pains that occur in people, how to recognize them and what we do about them. These are boring if I do all the talking with nobody interjecting. So by all means, use the chat box, ask questions, raise your hand, shout out things. It is totally fine. So a quick introduction. So over on 978 Worcester Street, or Route 9, we have our Newton-Wellesley Sports Medicine office, which also has 978 specialty services. So for all of you who don't know us, we have Bobby Nascimento, who's over there. He's one of our sports medicine physicians. He's the head team physician for Boston College. Smiling 2 over on the right is Doug Comeau, who's also on this, and he is over at BC with him. Doug provides our primary care sports medicine in the office. We have Drew Rogers, who is a sports medicine specialist who specializes in hip arthroscopy, so he is excellent for joint preservation. We have Maurice Albright, our pediatric orthopedist, who is there to take care of all of our kiddos who show up at 978 and coming through the walk-in. Daniel Gus is part of our Newton-Wellesley Mass General Brigham system, who is situated with us on Thursdays at 978 and sees foot and ankle patients for us. And then you have both myself and Dr. Foster, who are both sports medicine surgeons. Dr. Foster is our chair, and I take care of our sports medicine patients and shoulder arthroplasty cases. So a quick background, leg pain, we can skip the slide because it's going to make you laugh. You might want to hit mute on that one, John. So chronic leg pain in athletes is difficult to diagnose. It's not quite as simple as somebody running across the sidewalk and falling and saying ouch 100 times. So it's difficult to diagnose. It's ambiguous, it's non-specific. And the key to diagnosing is usually through a thorough history, which gives us the indication of what the problem is. Physical exam helps, and the diagnostic tests, in particular, the interpretation of the diagnostic test is incredibly important for this. So there are really, thanks, John, 5 main causes of leg pain that we're going to look at today. There is medial tibial stress syndrome, which most people call shin splints. There's a stress fracture, which is a scary one. There's popliteal artery entrapment syndrome, which is a pinching of the blood vessel on the back of the leg. Nerve entrapment, which provides nerve symptoms. And then we've got chronic exertional compartment syndrome. Keep going, John, we're good, thank you. So we're gonna dive right into medial tibial stress syndrome, also known as shin splints. It is a very common running injury. It happens in about 10 to 15% of people who come in complaining of shin pain, particularly as runners. The highest incidence is primarily in people who are running, getting back into running and doing distance running. However, it can be seen in any jumping sport like basketball, tennis, volleyball. It's typically caused by a combination of things. From an anatomic standpoint, there's overpronation, meaning the foot is kicked out to the side, so you are changing the entire biomechanics of the leg. Hill training can cause the pain, running greater than 20 miles per week, lack of shock absorption, and training errors. And when you look at lack of shock absorption and running greater than 20 miles per week, running shoes really need to get changed every 3 months or 300 miles, and most people ignore that. Go to the next one, please. Oh, perfect. So medial tibial stress syndrome, the pathophysiology is really just traction periostitis, which means that it's the soleus muscle is pulling on the side of the periosteum, which is the covering of our bones, and it causes pain. So typically people will come in complaining of pain at the junction of the mid and distal third of the leg, where it's highlighted red on the cartoon, on the medial side of the leg. So it's closer to the other side. It's usually just along the posteromedial border of the tibia, and that's where people complain of pain. So what you will see in these 5 different descriptions is, for the most part, the location of the pain is very different, although some of the complaints are the same. So when we look at imaging for this, we can use x-rays, we can use MRI, and we can use bone scans. To the left, you have a bone scan. To the right, you have an MRI. And on the left image, where the arrows conveniently are, you can see that there's increased signal in that area. So that tells us that there's increased blood flow, and where there's increased blood flow, there's usually a problem. On the image on the right, you can see, since I'm not driving, you can't see my cursor, but there is a bright white spot. Oh, perfect, John. There's a bright white spot right in the middle of the tibia, and that is where where there's a stress reaction going on. So these are very simple diagnostic tests that we can use to confirm the diagnosis, but usually the history and the physical exam give you a good indication of what the problem is. So the treatment for medial tibial stress syndrome is typically activity modification. So we start by decreasing running distance. We switch to cross training, meaning getting them away from running, getting them on a rowing machine, an elliptical, swimming, an exercise bike, changing what they're doing and getting them away from hills, and really focusing on changing their footwear as well, because once the insole of the shoe wears out, it's no longer providing any support. Physical therapy focuses on strengthening the inverters and everters of the foot, as well as using modalities. And the key for this is that if someone has pes plano valgus, meaning a valgus angulation of their foot, strengthening the muscles to realign the leg will help, because it puts a lot of stress on the inside of the leg. Operative management for these is few and far between, but when we do surgery, it is typically a release of the posterior compartment fascia, and it's primarily addressing the medial soleus bridge, because it's the soleus on the medial side of the leg that's causing the traction periostitis. So before we jump into stress fractures, anybody have any questions on medial tibial stress syndrome? All righty. So next we have a stress fracture, which is kind of moving up the line. So a stress fracture typically occurs from repetitive activity. So military recruits, runners, female athletes, and female athletes, when they present to the office with a stress fracture, you really have to worry about the female triad. All of you can think back to medical school when we talked about this, but you have to worry about disordered eating, dysmenorrhea, and osteoporosis. And the three of those go hand in hand. And if somebody presents with one of these, it is important to ask the right questions to make sure that we're not missing a bigger problem. Stress fractures typically bother people with changes in activity. So if they've changed the frequency with their running or exercising, the duration, the intensity, they can cause the repetitive stress, which typically happens on the front of the tibia. And that's the stress side of the tibia. So when patients present, they have an insidious onset of pain. It's usually after they change their activity, and the pain persists. It doesn't quite go away. So simple ways to diagnose it, and all of my colleagues up at 978 on the second floor have had one of our medical assistants run upstairs a number of times and ask if they have a tuning fork. So if we go to the next slide, you'll see that we've got a tuning fork and we've got simple tests. So typically on a physical exam, they'll have localized tenderness about the anterior aspect of the shin. They'll have swelling, they'll have pain with a hop. So you ask them to jump on one leg and it hurts. And then vibratory pain, which is what we can use a tuning fork for, is if you put the tuning fork directly over the tibia, and if you move it down the tibia, when you get to the area, as you approach the area of a stress fracture, or any fracture for that matter, people have increased pain with that. And it's a very nice, simple test that you can do if you've got a suspicion that this is what's going on. So once you get to that level, we have to start looking at some imaging. So you can get an x-ray. And on the x-ray on the left, you can see beaking of the cortex on the front, conveniently right next to the big L and where John's cursor is. And that shows you the dreaded black line. That means we're already in trouble. The beaking is a periosteal reaction, which means the bone's responding to what's going on. On the right side, you can see an MRI, and in this one, it's incredibly clear. You see the edema, and you can also see a break in the cortex. And once it gets to that point, it's very worrisome. Once you get the dreaded black line or a break in the cortex, the management can change very quickly from non-operative to operative. So treatment for stress fractures, if you catch them early enough, you change what they're doing. You slow them down, you protect, you can go protective weight bearing, you can consider a boot or a cast, switch them to cross training because it's the repetitive action and the impact that causes these problems. Bone stimulators have been shown to help. Their insurance covers them for the most part, and you can gradually return them to activity. So if we have a runner, you start them with a walk, jog, walk, and then you can increase it and slowly add in running. If they develop any recurrence of symptoms, you have to immediately back them down because the clock starts over. Unfortunately, if you get to the point that this is not going away, or you have the dreaded black line, or this has progressed to an actual fracture, it's treated with surgery, and the surgery is an intramedullary nail. And what that does is it protects the tibia, because when you have a stress fracture that's non-displaced, it's very easy to fix. Once it progresses, it becomes a fracture that extends through both cortices, where it changes the game a bit. Are we okay with stress fracture so far? All right, so we will keep moving. Popliteal artery entrapment syndrome. I rely very heavily on our vascular team. They've been wonderful. It's always important in the few hospitals that I've worked in to develop a relationship with our vascular department. And the reason is that patients who present with popliteal artery entrapment syndrome present with symptoms very similar to chronic exertional compartment syndrome, in that they will have cramping and pain in the calf muscle with exercise. And with popliteal artery entrapment syndrome, it's very similar to angina of the calf. So as you exercise, what happens is the calf will flex, and the popliteal artery runs between the two heads of the calf muscle, and it will get pinched and will actually cause ischemia of those muscles during exercise. And once you stop exercising and the muscle decreases in size and the artery flow increases, the pain diminishes. So the presentation, typically pain after high intensity activity. It's usually related to dorsiflexion and plantar flexion because you're flexing the calf muscle during those activities. It can be unilateral. However, in upwards of 83% of the cases, it's bilateral. Patients will typically complain of pain in the calf muscle. It's like claudication, it's a deep ache, it's a cramping, and it's very similar in presentation to exertional compartment syndrome. The physical exam, there's not much to find on a physical exam except for the potential for a decreased dorsalis pedis pulse. So what you can do is extend the knee and passively dorsiflex the ankle, and that puts tension on the calf muscle, which can cause a pinching of the popliteal artery, decreasing the dorsalis pedis pulse. The other way you can do it is with active plantar flexion, because it causes the same thing. So if you pick up a decreased pulse, that's when we usually get our vascular team involved and have them take a look. And typically what they'll do for a diagnostic workup is either an MRI, MRA, a dynamic ultrasound, or an arteriogram. So when you look at the right side of the screen, you can see the left, the popliteal artery, is that nice black artery going right down the middle of the leg. And when you go to the right side, you can see where it suddenly disappears right in the middle. And that's an indication that the calf muscle was pinching the artery during activity. So if this is a positive and somebody has popliteal artery entrapment syndrome, typically the vascular surgeon will take care of this by doing a surgical release of the constriction. And hopefully it doesn't get to the point where you have to bypass this, but if a simple release takes the tension off of the artery, then patients typically do fine with that. So that is now 3 out of our 5, and everybody in the audience has been quiet. Do we have any questions so far? All righty. So nerve entrapment. Nerve entrapment in the leg happens in a number of locations. We can go to the next slide if you're ready, John. So with nerve entrapment, you can get it in a number of locations. Typically, the common perineal nerve runs around the fibular head, and that is typically caused by trauma, meaning a tight brace. It could be a ski boot. It could be any number of things that are pushing on the side of the fibular head, which can cause a neuropraxia about the common perineal nerve. The superficial perineal nerve is typically associated with a fascial herniation. So the fascia, if everybody recalls, is the layer of tissue that goes over every muscle in our body. And what happens is there's a tiny little hole about 12 to 14 centimeters above the lateral malleolus, where the superficial perineal nerve exits the lateral compartment and goes through a little hole in the fascia. And what can happen is that during exercise or activity, the nerve can actually get pinched by the fascia where it exits, and that can cause pain. It can also cause numbness and tingling in the distribution of the superficial perineal nerve. So since nobody ever remembers any of these things, we put a little picture on the side so you can remember where all the dermatomes are and the distributions and the what each nerve does and where the sensation is. So typically presentation is pain with activity. With a common perineal nerve, it'll be the lateral leg and the foot. With the superficial perineal nerve, it can be the lateral aspect of the calf as well as the dorsum of the foot. The deep perineal nerve provides sensation for the first web space, so that will typically be intact in somebody with superficial perineal nerve entrapment. So if you look carefully at this image, you'll see these 2 round bumps on the outside of the legs, and those are fascial herniations. And patients, it's pretty amazing when they present to the office, they sometimes just say that they have a bump with activity and they don't know what it is. And then they get numbness down the side of their leg. And this is pretty indicative of a fascial herniation. And a fascial herniation is treated by increasing the size of the hole, not by decreasing the size of the hole. So diagnostic tests, you can do a nerve block, you can do an EMG. And if the tests are diagnostic and they actually have superficial perineal nerve entrapment, you can do a release. And it's a decompression with a fasciectomy. So the picture on the bottom right, there is a tubular structure going right across about a quarter of the way down on the screen. And that's the superficial perineal nerve. And directly to the left is the fascia that's overlying it, that's pinching it. And that's an arthroscopic photo from one of our patients in Newton-Wellesley. So that is the quick whirlwind tour of 4 of the 5. Now we're going to dive into chronic exertional compartment syndrome. This is more common than the others. And for those of you who have seen a portion of this talk before, we've had a number of you accurately diagnose exertional compartment syndrome and sent it to our office. So exertional compartment syndrome is very, very different than traumatic compartment syndrome. So traumatic compartment syndrome is when somebody has an acute injury and you, like a broken bone, and you bleed into the compartment, and it's an emergency to address the fact that the pressure is going up in the leg and it's causing muscle necrosis and injuries to the nerves. So in exertional compartment syndrome, it is not related to an injury. It's repetitive activity that causes the problem. So it was first described in 1948, and it was suggested that acute ischemic necrosis was the problem. Not too different in 2021, but the diagnosis is often missed or overlooked. In 1962, there was the first description of intracompartmental pressures, which helped significantly with the diagnosis of this problem. So quick history of this is in 1956, there was a 24-year-old football player who was having exercise-induced pain in the anterior aspect of both legs. They did everything for him. They rested, they changed the footwear, they tried a whole bunch of different things to get everything to settle down. And it was really only brought on by exercise. And when this athlete was exercising, he would get pain in both legs. And there were also fascial herniations noted about the anterior tibialis. So as the muscle pressure went up in the compartments, it actually pushed the muscle through the fascial herniation, which was what was causing the bumps on the side of the legs. So when this happens, it's exercise ischemia of the anterior tibialis muscle, or at least in this case for the anterior compartment. It was initially treated non-operatively. They tried medial heel wedges, they tried to change his activity, and it didn't work. So after 4 weeks of failed treatment, they decided that they needed to do something else. And the treatment for it was a compartment release. So very different than the way we do it today. The compartment release extended from the fibular head down to the lateral malleolus and left the entire compartment open with a fascia lata interposition. 6 weeks after surgery, had a significant improvement, and they repeated it for the other side. So after 4 years of activity and continued sport, the patient remained symptom-free. So this was our first description of this. Now, when we see it in our office, the incidence is about 30% of our athletes with leg pain. It's more common in the anterior and lateral compartments. And when we do see it in the posterior compartment, that's typically when I get the workup for popliteal artery entrapment syndrome. A quick refresher on the compartments of the leg. There's really 4 classic compartments that we all learned about. There's the anterior and the lateral, there's the superficial and deep posterior, and then there's the elusive 5th compartment. The tibialis posterior actually has its own fascial covering, and that may be one of the reasons why posterior compartment syndromes don't do as well as anterior compartment syndromes, because this compartment itself isn't released. So when we take a quick dive into the anatomy again to remember what is in each compartment, the compartments are separated by fascia, and the compartments have neurovascular structures in them. And those neurovascular structures can also cause some of the symptoms that we see. So patients don't only have complaints of pain, but they can also have paresthesias along the nerve distributions. Now, one common thing that we hear is when somebody has exertional compartment syndrome or even traumatic compartment syndrome, losing a pulse is a very, very, very late sign, because the pulse represents our systolic blood pressure. And that means that you have to get the pressure in the compartments to exceed your systolic blood pressure for that pulse to go away. So the pathophysiology of this is that muscles increase in size with exercise, and compartments can typically accommodate about a 20% increase in volume. Now, people who have very well developed muscles run out of that increase in volume very quickly. So as the compartments can't expand because the fascia is very tight, and as the pressure goes up, the muscles hypertrophy, the interstitial fluid increases, and the blood volume increases. So you have a number of things where you're pushing fluid into a compartment that's run out of space. So from a physics standpoint, this was very simply described by Laplace's law. So capillary membranes reach an equilibrium based on internal and external pressure. So as the pressure goes up, the arteries and the arterioles can't get any more fluid in, and you can't get any more fluid out. So you end up with this problem where you get all of this pressure inside the compartments that has no way to release. And as a result, you would develop muscle ischemia, which causes pain. And muscles only have blood flow during relaxation, not during contraction. So patients will typically present with a history of pain or cramping with activity, and they typically don't have the pain when they walk into the office. Some patients will get paresthesias if there's involvement of the nerves. For instance, the superficial perineal nerve entrapment is very common occurrence with anterior and lateral compartment syndrome. Patients can also develop a foot drop, and it's not a nerve-related foot drop, it's a pain-related foot drop. So they have difficulty lifting their foot up because the anterior compartment is causing a significant amount of pain. So if you watch these patients run on a treadmill, you can actually watch their foot start to drop on the side that's bothering them, and it will start to slap and their gait changes as they run. When they stop running or they relax, the pain typically dissipates pretty quickly, but if they return to activity quickly, it comes right back. So fascial herniations are present in about 40% of the cases, and the defect is about 1 to 2 centimeters. In this picture on the right, that's very similar to the arthroscopic photo that I showed you. That's the superficial perineal nerve running right in the middle, and that's about a 4 centimeter incision. You can use the Tinel sign, which means tapping over the nerve can cause paresthesias radiating distal. And very different than a hernia in the abdomen, for instance, we don't close these herniations because the muscle is trying to poke out to give itself some relief. You want to extend the herniation to give the muscle room to breathe. The typical way that we diagnose this is with compartment pressure testing. The image on the bottom of the screen is a Stryker compartment pressure test. They don't make them anymore. We now have Centurion compartment pressure tests at the hospital, which are the new generation. I won't necessarily say they're the better generation, but they're new. And in 1990, Pedowitz described a very simple test that we can do to determine if somebody has exertional compartment syndrome. So when somebody is at rest, the pressure in the compartment should be below 15. So what we typically do is we'll take a compartment pressure test in the compartments that are bothering them, and then we get them on a treadmill and I have them run to reproduce their symptoms. And I have them run until they tell me that the symptoms are bad, and then I have them continue to run until they tell me that the symptoms are horrible. And then they continue to run after that until they tell me that they hate me. And the reason is we really don't want a false negative on these tests. So they come off of the treadmill, and 1 minute after exercise, we test again. And if the pressure is greater than 30 millimeters of mercury, it's positive. Within 5 minutes after exercise, and somebody who does not have this, it should drop below 20 very quickly. If you have exertional compartment syndrome, that pressure will stay elevated above 20 for after the 5 minutes have elapsed. So the management, non-operative, to be perfectly honest, doesn't really work. You can try, you can change the training surface, you can change the shoe design, you can change what they do. The picture on the bottom demonstrates what pes plano valgus looks like. And you can see the feet kick out to the side. So you can try to realign the feet using medial heel posts and different shoes. But the problem is that this is really an inflow-outflow problem. And the only thing that really can make this go away is either a modification of the activity that you're doing, or you consider surgical release. So the indications are typically if patients show up and they've had symptoms for about 3 months or longer, and a positive compartment pressure test. They also have to be unwilling to stop the activity that's bothering them. And when we do the compartment releases, we use these through 4 centimeter incisions. They're very small. This is a nice pictogram showing what the compartments look like. If we go to the next image, you can see how small the incisions actually are. So those dots are about 4 centimeters, and that's it. We do a 4 centimeter incision. I make a 1 centimeter counter incision closer to the knee, and I actually run an arthroscope down. So if you go down to the next image, the reason why I use the scope is because you can actually see the fascia. The white stuff on the bottom of on the top image on the bottom is the fascia. On the right, you can see the muscle after the fascia has been released, so you can make sure that a complete release has been done. And then on the bottom image, that long white thing that John just beautifully traced is the superficial perineal nerve. So that was dissected out because this patient was having symptoms as well, and we want to make sure that the nerve is okay. So I know we're getting close on time on this, so we've kind of gone through this very quickly as to how I take care of these patients. So we can skip to the next slide, which I believe is post-op management for this. So if we're doing a unilateral case, meaning only one side, it's crutches to protect their legs. For both legs, we put them on crutches to slow them down a little bit. With anterior compartment releases, patients are typically back to running around 6 to 8 weeks, and they have an over 85% success rate. Posterior compartments are a little bit slower and they have a lower success rate. And that's mostly because of the elusive fifth compartment that I don't think was recognized when most of the studies were done. Now that it's a recognized compartment and has its own fascia, once that's released, patients typically do very well. So with that, I can ask if everybody has any questions. And we can go over a quick review of who's in our department. We did this at the beginning. So our Newton-Wellesley sports medicine team, we have Bobby Nascimento, Drew Rogers, myself, and Tim Foster. We take care of sports medicine problems, shoulder replacements, and hip preservation. On our next slide, we have Maurice Albright, who provides support for our pediatrics. Daniel Gus, who takes care of our foot and ankle patients, and Doug Camo, who is our primary care sports medicine physician. And for those of you who have not been familiarized with our 978 Worcester Street location, we have an orthopedic walk-in that started in February. No appointment is necessary. We are open from 8 a.m. to 8 p.m. Monday through Friday, 8 a.m. to 1 p.m. on Saturday and Sunday. We will see orthopedic patients who have orthopedic problems who need to be seen. It can be a chronic problem. It can be an acute problem. We get the patients in, we have x-ray, we have casting, we have bracing, and they are typically seen by our orthopedic PA staff first, and they get streamlined directly in to see one of the staff members for sports medicine, foot and ankle, peds, hand surgery, PC contributes for our hand volume. And we have a direct line of contact with our spine group as well.
Thanks, Jay. The one secret thing that we don't talk about in the walk-in center is you can always drop your kid off and then go right here in the corner because there's a great Dunkin' Donuts right there in the same building. So
there is a Dunkin' Donuts right there.
I know we're past time. I know we're past time. I want to ask you a quick question. I'm sure, I don't know if people are going to stay on, but I get a lot of questions in the office about footwear. You mentioned that a few different times here. I heard you use the 300 mile. I've typically seen 500 mile, but I know folks sometimes go to marathon sports and get them fitted. I mean, is that something you recommend, or how do you manage that in your office in sports medicine?
So I actually do recommend that. So if you know what kind of foot you have, so for myself, I typically go online every year and I look up whatever the recommendations are for people who have big, fat, wide feet, and I get the sneakers that fit me. When you look on Amazon, you pick the color that everybody hates, and they're $100 cheaper. For people who don't know what kind of footwear they need, I do recommend that they go get checked out. Marathon Sports is a good place. I don't recommend going to any of the places that are manned by or staffed by people who don't know about shoes. So you get the high school kids, the college kids who are home for break, who are there, who may not be able to identify what kind of runner you are or what kind of footwear you need, and then you end up with something that doesn't help. So there are sneakers for people who are pronators. There are sneakers for people who have pes plano valgus. Whenever I have patients who come in with medial tibial stress syndrome, I tell them to go online and buy medial heel posts. They're very simple. They can go in the back of their shoe and they will help correct that angulation. And it's amazing how quickly it will help relieve the pain on the medial side of the shin. It also helps with medial sided knee pain when patients don't have an injury, because it works all the way up the chain in the leg. So footwear is incredibly important, and it's one of those things that we all ignore, because at 3 months, your sneakers probably look fantastic and the color is bright and your laces are in good shape and the insole isn't doing anything anymore.
And then there's a question real quick. Sally wanted to know, good question, which person in your practice has the most expertise with posterior compartment syndrome? Sounds like a direct question.
I think in my 2.5 years of being in Newton-Wellesley, I think that right now I see more compartment syndrome than anybody else. So a good number of the leg pains come to me. I will work them up. If somebody is having calf pain or posterior leg pain and I'm worried about anything, I have a great relationship with our vascular team, and Chris Qualick gets them in very quickly. He'll do an MR, he'll either do the angiogram or do the dynamic studies and give me an indication as to whether or not he thinks it's popliteal artery entrapment syndrome. And if it is not, since their studies are not invasive, then I'll do the exertional compartment pressure test. For the anterior and lateral compartments, we don't send them to vascular. I just go straight to the compartment test if they're interested.
And Jason, you do those right in the office, that compartment testing, or how does that work?
So that's a very good question. So we go over to Wells Ave, and they have a room set up for us. So we will set up an appointment. We bring the patients over there. I examine them we have an exam room. I do the pre-exercise compartment pressure test. Then we go straight over to one of the treadmills. They have 4 in the corner, and we'll have them run on the treadmill with or without an incline to reproduce their symptoms. I watch how they run. I keep track of when their symptoms develop, how intense they get, and then we go straight back to the room when they've hit their maximum, and we test again at the 1 minute after exercise and 5 minutes after exercise. So they have a diagnosis before they leave.
Maybe you should do that in the cardiac rehab center. We can get a little stress test at the same time.
I think I get the stress test every time I do it.
All right. Well, thanks. We've run on overtime. We want to wish everyone a good Veterans Day next week. Remember, we won't be here. Good time to catch up on one of our other talks, and we'll see you in 2 weeks. Hope everyone has a great weekend. Jason, thanks again for doing this. Great talk as usual. Bye.
Oh, thank you for having me.